Well, good afternoon, everyone. So I want to start by just telling you for a brief moment about Triage Cancer. We are a national nonprofit organization that provides free education on the legal and practical issues that come up after a cancer diagnosis. And when I tell people I'm a cancer rights attorney, I always get asked, what's legal about cancer? And my answer to that is almost everything. So whether or not the Food and Drug Administration approves a treatment is a legal issue. Whether or not insurance covers that treatment is a legal issue. Whether or not you get to take time off work to get access to that treatment is a legal issue. We just don't think of those things as legal issues, but it's the law that provides protections and benefits and access to programs and services. And in the cancer community, we spend a whole lot of time talking about how those things have an impact on someone's finances. And we spend a lot of time talking about financial toxicity or financial hardship, you choose the term, but all these legal issues are actually contributors to financial toxicity and financial hardship. And when we tell patients about this problem, they know the problem. We don't have to tell them what the problem is, they experience it every day. And their question back to us as advocates is, why is this still an issue? If we all know that the problem exists and we spend so much time talking about the problem, why is it still a problem? And it's because there are a lot of contributing factors to financial hardship. We most of the time hear about those factors as around the cost of care and maybe insurance coverage and whether or not someone has insurance. But at Triage Cancer, based on our decades of doing this work, know that it's actually not just having insurance, but that it's having adequate insurance. And that's actually only step one. You also have to know how to use that insurance effectively. But there are also all these other contributing factors to financial hardship that have an impact on access to care and quality of life for patients. The problem in trying to educate the community about health insurance and having adequate health insurance is that no one actually understands health insurance. So this used to just be my anecdotal opinion based on doing this work, but now we have the data to back it up. Only 4% of Americans could actually define the 4 key terms used in health insurance. So if we don't understand the words, how is it that we're actually able to make good choices about our health insurance coverage as consumers? So this same study found that 40% of Americans said that they were very confident that they could pick a health insurance plan that was right for them. But I would argue if they don't understand the words, they were probably overconfident in their choices. So when we talk about navigating systems and the issues that I'm going to talk about in the rest of this presentation, our biggest hurdle is knowledge. And I often say, as an advocate and a lawyer, if all you needed was a law to solve a problem, you wouldn't need lawyers and you wouldn't need law enforcement, right? Just having the law only gets us the first step. But in the work that we do, we also need education and navigation around those laws. We work very hard as an advocacy community to create protections. We work very hard as an advocacy community to create policy and legislative change. But if no one knows about the outcomes of those changes, why did we bother? Why did we take the time to pass those protections? And at Triage Cancer, we actually use a multi-tiered approach to education to make sure that the whole ecosystem of our healthcare system has a better understanding of how to navigate those laws. Now, at Triage Cancer, I mentioned we think that having adequate health insurance coverage is the #1 contributor to financial hardship. In the United States, there's only 3 places where we get our health insurance coverage. We're either getting it directly from an insurance company, we're getting it through the government, or we're getting it through an employer. And about 50% of people in the United States get their health insurance coverage through an employer. Most people who have employer-sponsored insurance don't look at their other options for insurance coverage because they're getting insurance coverage through an employer. But we know that many employer plans are not adequate health insurance plans for a variety of reasons. And so we encourage people to actually look at all of their health insurance options to figure out how to pick the best plan for them. But as I mentioned, that's really just step one, and we have a lot of resources to help people through that step. But for the rest of the presentation, I want to focus on how knowing how to use your health insurance can actually lower your costs and improve access to care. And while clearly at Triage Cancer, we are a cancer-related organization, all of the information that we provide to people is typically not cancer-specific. So we often say it's all the things we should have learned in high school, but no one ever taught us. So I'd like to introduce you to Carmen. She's 29 and was diagnosed with breast cancer, and her doctor told her that her treatment might affect her fertility and her ability to have biological children in the future. Her doctor recommended fertility preservation, and she decided that she wanted to pursue it, but when her healthcare team checked with her employer-sponsored insurance plan, the insurance said it was not a covered benefit. Carmen can't afford to pay for fertility preservation out of pocket. What are her options? So this is a pretty common situation in the cancer community around fertility preservation and the response back from insurance companies. And there's a lot of advocacy efforts right now to pass state-specific legislation to improve access to fertility preservation. But that takes a long time. Carmen can introduce us to our topic of appeals. This is just some of the tons of data that we have across various types of insurance related to the appeals process. Between 2016 and 2020, there was a 23% increase in claim denials. And this particular survey done by the Kaiser Family Foundation found that 18% of adults had experienced denied claims. And it was across different types of insurance coverage, whether it's marketplace plans or employer-sponsored plans, Medicare or Medicaid. In a separate study by the Commonwealth Fund, in appeals post-care, so after someone's received care, their insurance company denied coverage. 40% of those adults said that they experienced a claim denial for something they thought was going to be covered, and less than half of them actually appealed. Why? They didn't know they had the right to. Prior to care, 17% of people said they experienced a denial. So here we're talking about prior authorizations. And again, 45% of people who didn't appeal didn't know they had the right to. It also comes up in Medicare. So from 2021 data, there were 2 million requests for 35 million prior authorization requests, 2 million were denied, 200,000 were appealed. So a very small percentage of people are actually appealing those denials, but the people who did won 80% of the time. So there's value in actually going through the appeals process. But we're not just talking about process, right? We're talking about people who have been actually prescribed care by their healthcare team who thought it was medically necessary that they receive access to that care. So the real impact of these denials is patients either not getting access to the care that they were prescribed or paying for it out of pocket when their insurance company should have. So when we talk about the appeals process, it's not easy. So as advocates, we often encourage people to do things, but the actual steps of doing things can be barriers for people. So step one in appealing a denial is figuring out what type of insurance you have, because the type of insurance that you have greatly impacts the process. And sometimes will actually impact outcomes, because there are certain types of insurance that have better consumer processes. And I want to explain a few of those. So in addition to knowing what type of plan you have, if it turns out you have an employer-sponsored plan, then you have to know what type of plan it is. How many people in the room have an employer-sponsored plan? How many of you know whether your employer-sponsored plan is insured or self-insured? I'm super impressed, because that is not the average consumer. So for those of you who are not familiar, a self-insured plan is where an employer, instead of going to an insurance company and buying an insurance policy for their employees, decides that they're effectively going to set aside a pool of money to pay directly for their employees' healthcare costs. But on the practical side of that, they hire a third-party administrator to actually manage the claims and the paperwork for that plan for their employees. And they hire an insurance company to do that. So if you look at the card in your wallet, it might have an insurance company's logo on it. You pick the company, but they're actually not providing the insurance plan for that employer. They're just handling the claims processing for the employer. So the reason this matters is that the law applies differently to these two types of plans. Whether you're insured or self-insured, you have access to different consumer protections, which you may or may not have known. So I want to focus for just a minute on one example of the appeals processes. And this is specifically for individuals who have an individual health insurance plan or for those funded or insured employer plans. If you are denied coverage, you have access to appeal that denial. You can go back to your insurance company and say, I'd like you to reconsider. And there are specific rules for this internal appeals process. And unfortunately, the insurance company gets to decide the rules. So each plan's rules might be different. They might say things like, you have to fax in your appeal, or you have to email your appeal, or you have to mail your appeal, and you have to follow those steps specifically. You also have to follow the timelines, and there are specific timelines for internal appeals. But the key thing to know is when we're talking about care that hasn't been received yet, but that has been prescribed, so prior authorizations, if someone's health is going to be impacted by that delay in access to care, you can file an urgent appeal. And the response back to that has to be within 72 hours. So the internal appeals process can be filed urgently. If it's still denied, and you have one of these types of plans, the Affordable Care Act made it federal law that these plans also have to offer an external appeal, which means you get to go outside the insurance company to an independent entity, and they get to decide whether or not it's medically necessary that a patient receive access to that care. This is actually huge. So this was supposed to be the consumer protection that created a way for people to get unbiased decisions on medical necessity. The decision is binding on the insurance company. So whatever the independent entity says, the insurance company has to cover. This is a free process if you're using the HHS process, but if you have a state process that uses an independent review organization, the maximum cost that they can charge for the external review process is $25. So the question is, to do all of this, is it actually worth it? Based on the data that we have since this has been in effect, on average, between 39 and 59% of the time, depending on the state that you're in and the year, patients are successful at the external appeals stage. So, you know, I'm a lawyer, I don't do math, but about 50% of the time, we're saying that these decisions are being overturned in favor of the patients. So it is absolutely worth it for patients to pursue. So again, there are rules with respect to the external appeals process. You have to file within 4 months of receiving the internal appeal. And the decision, if we're talking about post-care, is 45 days. But again, there's a provision for urgent appeals, where if care is going to impact health in a serious way, negatively, then you can file an internal and the external appeal at the same time and get both back within 72 hours. So that's pretty significant. But you also have to understand the reason for denial, because you actually have to gather the evidence to justify that medical necessity. So most often in the cancer community, we're hearing arguments around it's not medically necessary, it's experimental, it's investigational, it's not a covered benefit. Now, there are definitely things that are excluded from plans that aren't covered benefits. Cosmetic surgery is typically a pretty good example of that. Weight loss surgery. In some plans, I've seen wigs specifically excluded in plans. So depending on the plan, there are going to be specific exclusions. But that's different than having something that is medically necessary that hasn't been specifically excluded and saying that it's not a covered benefit because it isn't on the list of things that are covered. There's a difference there in the law and in the legal argument. So when people are gathering evidence of medical necessity, they have to rely on their healthcare team because it's their healthcare team that knows why, right? The healthcare team prescribed a particular reason for a medical purpose, and that's the information that patients need to be able to include in their appeal. We also have a lot of tools to help people through this process, including an appeals tracking form, but this is where it's important to take notes. Lots of notes of every conversation with someone at an insurance company to document all the steps that someone has actually taken through this process. We don't recommend the Post-it note method for this. The other hurdle that we see with the appeals process is that, and then we hear this from physicians a lot, is how frustrating the peer review process is. And that is when the insurance company's medical representative, whoever that might be, meets with the healthcare professional that has prescribed the treatment for a patient. And they have a peer-to-peer conversation around that medical necessity issue. The problem is that peer review is typically not peer-to-peer. So you might have a retired podiatrist talking to someone who is up on the latest in precision medicine and oncology. Their knowledge is not at the same level in terms of the latest care, standard guidelines, treatment, things like that. It's also held out to be the last step in the process of appeals. So I can't tell you how many physicians I've talked to over the years who said, well, it was denied at peer review, so there's nothing else I can do. There's a whole nother step in the process called external appeals. That's what can happen. But the problem is that the insurance companies make it seem like the peer-to-peer review step is the last step in the process. And it's not. It's just the last step in the internal appeals process. So I want to come back to this idea about knowledge that I started with. The biggest hurdle in people getting access to care is the fact that they don't know that the appeals process exists, specifically the external appeals process. So this is data just from marketplace plans from 2001 because they're actually the only type of plan that has to provide this level of detail on their denials and on their appeals rates. So in 2021, there were 48 million claims denied. 99.9% of those denials were not appealed, even to the first level of appeal. So they didn't even get to the external appeal stage. So I'm going to say it one more time. 99.9%. Which means if you figure if half of them would have been successful if they'd got to the external appeals stage, that's 24 million people who would have gotten access to the care that was prescribed by their healthcare team. But the flip side of that is that's 24 million people who didn't get access to the care that they were prescribed by their healthcare team, or they paid for it out of pocket, which is a major contributor to financial hardship. And then the question that I've heard so far today has been around how do we get patients access to financial assistance? Well, maybe we could avoid the need for financial assistance to begin with by making sure that their insurance coverage is actually covering their care. So coming back to Carmen, the reason Carmen is such a great example for the external appeals process is because of the time sensitivity involved in access to fertility preservation. It's actually delaying access to cancer treatment because she has to go through fertility preservation first. So in this case, there is an argument that you could file the internal and the external appeal at the same time because she's delaying access to cancer care and get a response back within 72 hours. And there is certainly, at this point in time, enough medical necessity evidence about the need for fertility preservation in order to preserve your biological ability to have children before going through cancer treatment. So the medical necessity argument is there and the process is there. We just need patients and providers to know it. So the interesting thing about the external appeals process is that it could also potentially be a solution to alternative funding programs. So for those of you who are not familiar with AFPs, this is a program that is being marketed by third-party vendors to employers that are choosing to have those self-insured plans. And the way that these programs operate is that they tell employers they can save them money because they exclude specialty medications or even just very expensive medications from their formulary. They're just not going to cover them. So they carve them out from coverage for these plans, or they just deny prior authorizations. Then, because employees don't actually have coverage for those drugs, they recommend to the patients that they go to the pharmaceutical companies or the manufacturers to apply for the patient assistance programs being offered by those companies to get access to those drugs. So shifting the responsibility from the insurance company, or the employer in this case as the insurer, to the pharmaceutical companies. Unfortunately, pharmaceutical companies only have so much money to go around for these programs and have chosen to actually change the eligibility requirements for the programs, which basically leaves patients in this particular situation in the cold. Because the patient assistance programs were intended to help people who truly didn't have coverage. And so now we have patients caught in the middle. So the practical implication of this is actually pretty significant. The interesting thing now is that employers are now coming around to the problem that they created by using these alternative funding programs because they didn't understand how it was going to have an impact on their own employees. There are also some really interesting legal issues related to AFPs, specifically around the lack of coverage. So under the Affordable Care Act, plans are required to provide coverage for essential health benefits. Excluding an entire class of drugs from coverage might actually be a violation of the ACA's essential health benefits requirement. It might also violate HIPAA, the Health Insurance Portability and Accountability Act's non-discrimination requirements. Sorry. And so I just want to say how diligent our AV team was in getting us set up, but they have abandoned us in this room, so I can't help. So might also be a violation of HIPAA, the non-discrimination requirements, in that if it is excluding a class of drugs, it's a class of patients who actually need access to specialty medications. And then there might also be an ERISA claim, and that it's a breach of fiduciary duty, that the plan is eliminating a coverage and acting in their own interests as opposed to the beneficiary's interests. And ultimately, if someone is being denied coverage for something that is medically necessary because the plan just doesn't cover it, there is an argument to file an external appeal in that situation and make the argument for medical necessity and utilize the external appeals process to address the carve-out coverage problem. To my knowledge, no one has tried to do it yet, but I think it's because no one knows it's a potential solution. So, we have a lot of resources at Triage Cancer to help people through the appeals process, depending on the type of coverage that someone has. And I do want to mention that we rolled out last year a program called Triage Health, which was basically to make all of this information available where it doesn't have cancer on it, to make sure that people could utilize the information and not be deterred because it says the word cancer. And then we have a couple of upcoming events where patients and healthcare teams and advocates can actually learn more about these topics in much greater detail, including our Triage Cancer Conference series, which again is not cancer specific. And then we have a monthly webinar series, including one coming up on September 26th, which does a deep dive into the changes coming to Medicare. And then for those of you who do this work as advocates, we have a training specifically for you where we provide free continuing education for patient advocates as well as healthcare teams. So with that, I will take questions. But if the plan is, sure. So she's asking if the patient has a prior authorization, but then the plan is saying that they won't cover it. My question is, how did the plan say they weren't going to cover it if they gave the prior authorization?
Through an AFP specifically, so payer matrix got involved.
Oh, so after the fact.
It's before the fact.
No, but I mean, like, the plan gave the prior authorization, then an AFP got involved. Same thing. It's still going through the external appeals process because especially when we're talking about self-insured employers, right? So this goes back to the ERISA problem where there's a fiduciary duty to basically operate the plan in good faith. So if the plan has provided the prior authorization, patient relied on that information, now we're post-care, then an external review to ensure that the plan actually covers the care. There's it all has to be based on medical necessity. External reviews are all about medical necessity. So it's about making the argument and taking it externally.
You have a question? Okay, the mic's on now. Oh, go ahead.
That's pre-care, right? And the PA is already approved, and then you have AFP involved to manage and then if the PA is already approved, and then they have a AFP involved to manage the cost, right? How can that still work? And if they don't have an option of external appealing,
You
because
do
the PA is
still
already
have an
approved.
option for external appeal in the that's like too many words. In the prior authorization process, if they have said no, there is the ability to appeal that externally. And because it's pre-care, there's even a better argument for urgency, assuming that there is a medical argument for urgency. But typically, it's delaying access to care. So you could file the external appeal urgently.
Okay, we have time for one more question, maybe one or two. But if your question is not answered, you can go on the Swap Card app, and if you click on this session, you can type in your question there, and I'll get you that information later.
So if an employer is using an AFP and it's a possible breach of ERISA, in the end, isn't it the employer's responsibility to cover that cost?
In the end, it's the employer's responsibility to cover the cost of the care that was denied coverage.
Right.
So if you're filing an ERISA claim in court, that's the only remedy that you get is the cost of the care.
Got it. Thank you.
Okay, can we squeeze one more in really fast? Okay. Sorry, we're on.
Hi, these are exactly some of the issues we've raised with Department of Labor, HHS, and Treasury. And our argument has been that exceptions process and the appeals process. Unfortunately, AFPs say you don't have that right to appeal or an exceptions process until you've gone to apply to and see if you qualify for. And I know, but that's what they're saying,
not
and
what the law
that's
says.
what they employ. But DOL has asked, they're trying to ask us, well, what authority do they have on these self-funded plans? And so we are bringing in the exceptions
ERISA.
process. Yes, there's controversy on whether the external appeal, right? Nobody's really pushed the issue on the external appeal, but we have had incidents on Major Cancer Center where it was deemed medically necessary, and still the plan said, well, that's medically necessary, yes, but you still have to go through the AFP process. And these are the issues we brought up with DOL and all, and saying, there really needs to be, one, a clarification that the exceptions process applies, and that there can't be a predication on an appeals process or an exceptions process, because that would be an unreasonable claims procedure.
I think you have to be really careful in the language that you use, because appeals process and exception process are two totally different
Right,
things.
they are, right.
An external appeal is a legal right, and it's about the plan, not about the AFP. So the AFP can choose to make a decision on behalf of the plan, but at the end of the day, it's the plan's responsibility. So if the external entity says that it's medically necessary and the plan has to cover it, the plan has to cover it.
Yeah, I'm just saying that's not in reality how it's working to date. So we've
And
raised this with DOL, yeah.
That's the problem, because no one is holding the plans accountable. So I apologize, because I have a plane to catch, and
Yes, I'm
there's a
sorry.
next
I'm
session.
gonna cut it.